right, so we are here with another PCBH Corner. I'm Dr. Beachy and I'm joined with
Dr. Bauman.
The topic of the hour is visit limitations in PCBH. So a lot of times you'll see on job descriptions, you'll hear in introductions of BHCs, and when maybe PCBH is discussed, it talks about that the service is going to be 1 to 4 visits, or 1 to 6 visits, or 2 to 6 visits, and that essentially these are visit limitations so that you can reach a broad range of patients. So I really am curious to hear from your perspective what you think about putting visit limitations on your PCBH practice.
Yeah, my mind goes a bunch of different ways.
Yeah, we're just going straight.
We're going straight there. And I think the one thing that my mind says from the beginning is that, you know, through all these topics and these PCBH corners, that we want to have grace for everybody that's participating in these conversations. While you and I are going to have specific thoughts and opinions about this, we really hope people share their thoughts and opinions about where their mind goes. When I hear someone say 1 to 4 visits or 2 to 6 visits, that's what our length of care is going to be. I think it alerts to me, or my mind makes the assumption, that there might be a little bit of a misunderstanding about what the model of primary care behavioral health is.
Okay.
So I think that would be an important thing for us to discuss. And then I think there's also a part of, there's fear, which goes back to that idea of this misunderstanding of what primary care behavioral health is. I feel for a lot of our BHCs that are put in situations that they're asked to do things that they might not feel confident in or comfort in doing. And a lot of times I think the 1 to 4 visits makes it a little bit easier, makes their job a little bit more, they're able to understand it in a lot of ways. But I think where my mind goes, and you know, this is where I think you've done a good job of talking about this before, is the reason why I think a lot of people say 1 to 4 visits is that probably really mature PCBH programs, when they look at their data, it is probably 1 to 4 visits.
Right.
How often they see with their patients. The difficulty is, though, we then assume that the reason why it's 1 to 4 visits is because we set out from the beginning to have it to be 1 to 4 visits.
I think I see where you're going to go with this.
When it was more actually probably a reflection of the context that that BHC was in. And my assumption about that context is that they're in a place that allows for the integration to happen, that the BHC has an understanding of Gather, PCBH, they have an understanding of the 4 C's in primary care, and then the result of that is, on average, 1 to 4 visits per patient. I would guess, though, the BHC didn't think from the very beginning, I'm going to set out for it to be 1 to 4 visits. What's your mind go to? What do you think?
Exactly. So I'm assuming, if I'm hearing you right, is that you're saying the BHC who's in maybe a mature program and have had a lot of training and they feel confident operating in primary care, essentially. They're going out and they're being a generalist. They're being accessible, they're being team-oriented, they're having high productivity, they're being an educator. It's routine care, right? All the aspects of Gather. And so that's their guiding principles. And so as they're operating through the cadence of their clinics, they're showing up, being with the patient and saying, okay, we're going to make a game plan. And then when they're, same way with medical providers, when the patient is on the right trajectory, we start reducing ourselves out of the care, reducing the amount of visits per se. So if a patient comes in and they're dealing with bronchitis, they're seeing the PCP, they have a couple of visits and then they check their breathing and we're doing great. Okay, will you call me if you need something or something else comes up? Same thing with PCBH. Your BHC, you're addressing maybe anxiety, they're making some changes in their life, maybe they decide to go back to school. You guys came up with a plan for that and worked on some time management once they got into school. They're on the right trajectory, and it's like, all right, so we can kind of reduce that follow-up visit at that point. So then if you follow those basic principles, what's going to shake out when you look at the metrics is that if you look at the average visits per patient, it's going to fall into that 2 to 3 visit range.
Well, it's really interesting because I think it also shows where, you know, a lot of people talk about that, you know, you should have 50% of handoffs or same-day visits with their PCP, and then 50% should be follow-up. No one's really done a study about that to show that that's a thing. What's interesting, though, in our data, that actually shows out to be true.
It does.
That it's 50% are same day handoffs and 50% are follow-up.
I don't think we could have hit it if we tried
No,
to
that's
necessarily.
And I think that's the point, right? And that's where this is also the same thing about this 1 to 4 visit thing. What's interesting is I think people's efforts then to make it 1 to 4 visits actually creates a lot of different problems, a lot of different contexts, contextual things that are difficult.
I'm very curious where your mind goes if you are, say you're shadowing a brand new BHC, and once again, we say this with the utmost grace, it's probably how somebody was taught, blah, blah, blah. You come in and you observe the introduction, and the patient says, so we're going to meet 1 to 4 visits, so we only have 4 visits together, or up to 4 visits together, and then they do their introduction. What type of relational frames or associations does your mind make, or that you think that the patient would make when you kind of hear that?
So I have 3. I have 3 that my mind goes to, and chime in with yours as well.
I'm gonna write this down.
when you have yours. I think the first one is that if I was a patient and I had someone come in and say, we only have so many visits together, even honestly, even if someone even capped it a little bit higher and said, we only have 8 visits together, I think just my relational frame would be like, I don't know if I want to get real with them. Like, I don't know if I want to tell them everything that's actually going on, if I'm going through a contextual interview and being forthcoming about that, because there's a finite amount of visits I'm going to have with this person.
Right.
When I hear someone be more open-ended about it, like, hey, you might get what you need out of 1 visit. We're in primary care. We're going to be here always for you. I feel like I create a relational frame of like, oh, like I'm going to have a relationship with this person for their life time. The second thing is that when I hear 1 to 4 visits, I often, similar to what I hear when someone says brief, my mind immediately goes less than. Superficial, less than.
Not as good as therapy.
Correct. The third thing that my mind goes to is that, and I think we should maybe do another PCBH corner about this, we have done a terrible job of training people, or we just haven't even discussed it really, about how do you discriminate when someone's supposed to follow up and when they're not supposed to follow up. The one thing that's nice about the 1 to 4 visits is like, you have a very clear parameter. Once you hit 4 visits or once you hit 6 visits, that means I no longer, you've gone past what I'm supposed to be doing. It's an easy thing that I'm going to have someone refer around.
Right. And not to go on a completely different tangent, but a lot of places, understandably so, want to come up with a brief protocol for filling the condition. So we're going to have 4 visits on anxiety. And that's not, we're not saying that that's wrong, but then it also sets up this idea, the way I would look at it in PCBH is, what if they don't need 4?
Well,
or what if they need more?
Correct.
Or they need, and it makes sense to want to go to 4 because 4 is more manageable than 16.
I think this conversation, 1 to 4 visits, reflects a lot of different contextual variables. I think the one thing that it definitely, 2 things, that there's this protocol-driven way that we do mental health treatment. I think that's one of the things. And then 2, we have never trained or talked about mental health being something that is episodic, that mirrors what primary care does. Right. So I still struggle with this. This is probably one of my biggest still difficulties that I have is, how do I know when people are supposed to follow up? And how am I discriminating against that? How am I intentionally discussing that with patients?
So basically, once again, we are trying to take what we had in mental health, the traditional mental health setting, and then force it into primary care. And I'm not saying that that's right. I'm not saying that that's wrong. I'm just thinking that maybe we would be better off to really understand what primary care is trying to do. Really put our studies into not transitioning what mental health is and then trying to force it into this other thing. Maybe we need to start with understanding the context we're in first and foremost, and then work backwards from there.
That was really well said. Because I think that's exactly where we get into problems at. We take this mental health approach and we just like try to mold it, try to change it, try to do whatever to fit in primary care, rather than us taking the responses you said. Hey, well, let's look at the context of primary care and come up with something completely maybe a little bit new. Now, let me ask you this as we begin to wind down a little bit here. Where does your mind go as far as like, oh, I don't want this to come off a certain way. Like, I don't want this to be taken in a certain way of what we're trying to promote.
I guess maybe I want there to be something else in place as an alternative. And I know that we've given some ideas, like understanding the GATHER acronym of PCBH, understanding the 4 C's. But if we're going to not do 1 to 4 visits, I would like an organization or an individual to have a clear understanding of foundational principles. We're never going to have the right answer because the right answer is completely contingent upon the context. And the minute the context shifts, it can change the answer. So we can't even answer the question of, well, is having 4 visits right or wrong? I couldn't tell you that unless I knew the whole context. So yeah, that's where my mind goes, is I just want to have something else in place, because if you're listening to this and saying, wait a second, this is one of the reasons why I got into the job, and this gives me parameters, and this makes sense, and this quells my fears, and what if we go too deep? What if we go too long? What if this happens? What if that happens? I would just urge folks to look to your PCPs, look to your family medicine providers, look at the context that you're in. How do they manage it?
Right.
And then start taking a lot of that and infusing it into your practice.
Because I really liked what you said there, where it's like, you know, in PCBH, seeing someone for 8 visits might be true. That might be true within that context. Seeing someone for 3 visits might not be true,
right,
in a certain context, right? So that's where I couldn't agree more, that these ideas, in my mind goes, what I don't want to have people misunderstand is exactly what you were just saying. We're not saying that it's not going to be 1 to 4 visits. Most likely, if you have on average, a robust PCBH program to hit our community, to do gather, to do the 4 Cs, it probably will be 1 to 4 visits. That's not the goal, though. The goal is for us to be able to provide a service that mirrors primary care,
right, rooted in gather,
rooted in those 4 Cs.
And what is the best thing about primary care in many, many, many cases? Access. What does mental health across our world and country struggle with? Access. So we're not, that's another fundamental difference. We're not necessarily saying we are curing depression or curing anxiety. That's a good one too,
right? That people might not need a certain amount. Like, you know, I think that's a really good point too. Yeah, my mind just goes, I think that's we're not curing this in this amount of visits or...
Which goes back to primary care. Understand why it exists in the form that it exists.
I agree.
So
I agree.
That's the take-home message.
I'm really excited to hear people's thoughts, comments. You know, email us, comment on the YouTube video itself. Definitely would appreciate people subscribing to the YouTube so you get updates on different videos, whether it be PCBH Corner or techniques that we're showing. Definitely reach out with other topics or ideas. Any other final thoughts?
Just once again, instead of making decisions about 1 to 4 to 1 to 4 or to not 1 to 4 as the visit limitations, to just really understand the context that you're working in, understand the organization that you are integrating into, fundamentally what are they trying to accomplish, and then mirror your goals and your philosophy around that. That might give you more direction and more clarity than necessarily making a metric goal.
I feel like we end every single PCBH Corner with the same thing. It's an and, not an either or.
And now I'm going to beat myself up because I do think metrics are really important, but not just saying, okay, we want 1 to 4. Use metrics to inform and go back to what are you trying, what is the goal and the mission of the organization.
Metrics are that reflection of the value, but not the goal.
We should stop.
There we go. Hey, thanks for joining us today.